Welcome, I'm Don Renfrew, and I'm going to be speaking about the cranial nerves, sinuses, and neck masses for about the next hour. I'm a radiologist with the Radiology Associates of the Fox Valley. We're a private practice radiology group that covers the north central portion of Wisconsin, and we have about 32 members and cover 9 separate hospitals. I work predominantly at this hospital, which is Door County Community Hospital in Sturgeon Bay, Wisconsin. There I am the medical director of radiology, and I also host the monthly grand rounds where we talk about interesting cases or tumors. Along with the hospital, there is North Shore Medical Clinic, which is a multi-specialty clinic that is part of the hospital. And in that clinic there are several primary care practitioners, as well as internists and nurse practitioners and family physicians, as well as physician's assistants. There are also surgeons in the clinic, and to make a long story short, I found that when presenting the material at grand rounds, many people were more interested in aspects of radiology which are not traditionally taught, such as what studies to order when and what the indications for studies are, than they were in traditionally taught radiology materials, such as the anatomy noted on radiology exams or the physics of radiology. So I started making lectures which have to do with what study to order for what circumstances in radiology, and that is the basis of this set of lectures. Now, as far as primary care practitioners goes, more and more primary care practice is likely to be done by nurse practitioners and physician's assistants as time goes forward. And so these lectures are aimed toward not only family medicine physicians, of which there seem to be fewer and fewer through time, but also physician's assistants and nurse practitioners who are practicing primary care and may want to order radiology studies. Now, as you know, you have many imaging options for imaging of cranial nerve symptoms and sinus symptoms and neck masses. And this can be a kind of a challenging and confusing area. At the same time, you want to order the right test the first time, every time. And my goal in the next hour or so is to provide you with enough information to be able to do that. So I'm going to review imaging options as well as some clinical features about cranial nerve symptoms, sinus symptoms, and neck masses. Now, cranial nerve abnormalities, you know, we do have to review a little bit of anatomy, a little bit of physiology, a little bit of function of the cranial nerves to know what to do here. And basically the best summary I can give regarding cranial nerve abnormalities is that symptoms of cranial nerve abnormality may require an MR of the brain. The first step of evaluation of patients with suspected cranial nerve abnormality is going to be a history and physical exam, and you're going to try to decipher whether the symptoms are actually arising from the cranial nerve itself, or if the symptoms are because of an abnormality of the brainstem or somewhere else in the brain. In other words, more of a central process than a peripheral process. Now, as a generalization, isolated involvement of a single cranial nerve is likely to be caused either by intrinsic dysfunction of the nerve, which typically won't show you much on an MR, or it might show you some contrast enhancement on the MR. And occasionally, MRs will show you a mass compressing the nerve. Now, what about cranial nerve anatomy and function? And we'll go through the cranial nerves one by one, but just to kind of recall, as this table notes, that the cranial nerves are named for their location as they come off the brainstem. The first cranial nerve is the olfactory nerve, and it's responsible for smell, so your main associated symptom is going to be a lack of smell or anosmia. The second cranial nerve is the optic nerve, and of course that's responsible for vision, so decreased or absent vision is going to be a cranial nerve symptom of cranial nerve 2. The oculomotor, trochlear, and abducens nerve kind of tower the extraocular muscles, the superior oblique muscle, lateral rectus muscle. And the main symptom you'll have from those three cranial nerves is double vision or abnormal eye motion. The trigeminal nerve controls facial sensation and the muscles of mastication, so the primary symptom with trigeminal nerve abnormality is facial pain. The facial nerve, on the other hand, controls muscles, and the primary symptom with facial nerve abnormality is going to be Bell's palsy or paralysis of the face. The vestibular cochlear nerve is a complex nerve involved with both equilibrium and hearing, and you're going to have four different things to think about: dizziness, vertigo, tinnitus, and hearing loss, and we'll kind of review those. The glossopharyngeal, vagus, and hypoglossal nerve, as well as the spinal accessory nerve, you're mainly looking at impaired swallowing for those nerve abnormalities. So, symptoms from multiple cranial nerves or other additional symptoms like headache, abnormal unexplained pain, non-cranial nerve neurologic abnormalities that suggest a brain abnormality should have an MR done without and with contrast. Now, your routine brain sequences are usually supplemented in these cases with thin cuts through the pituitary gland for cranial nerves 2 through 6, or through the posterior fossa for nerves 7 through 12. And now those thin cuts will be done without contrast. Okay, so let's start out with cranial nerve 1. Your symptom is going to be anosmia, as I mentioned before, and a gradual onset of the loss of smell can accompany sinus disease, allergic disease, or dementia, whereas sudden onset of loss of smell can be secondary to head injury or viral infection. Patients with acute onset of anosmia should probably be referred to an otolaryngologist for examination of the nasal cavity and paranasal sinuses. Imaging studies can include CT of the paranasal sinuses if there are symptoms of sinusitis, which I'll talk about in a while, or brain MR if there are symptoms of central nervous system disease. Cranial nerve 2 symptom is going to be decreased vision or loss of vision. Chronic vision loss typically is a concern of an optometrist or ophthalmologist rather than a primary care provider, but the primary care provider may see patients with acute vision loss. Acute transient monocular vision loss or amaurosis fugax may be caused by embolic or hemodynamic vascular abnormalities, and this symptom represents a TIA stroke equivalent. I've talked about that in another lecture, and you need to manage these patients as if they're having a stroke or TIA, which includes aggressive, timely workup, either on an inpatient or a closely monitored outpatient basis. Your imaging needs to include MR of the brain, and typically with that, either CT angiography or MR angiography of the arch and great vessels, and ultrasound of the neck vessels as an alternative to the CT angiogram or MR angiogram. And you're looking for vascular occlusion, stenosis, dissection, other causative vascular abnormalities in somebody with amaurosis. Now, when you have acute monocular vision loss in a younger patient, especially if there is associated movement disorder or an afferent pupillary defect, you should be thinking about MR of the brain without and with contrast, and you're going to be looking for multiple sclerosis. And again, I've talked about multiple sclerosis in another one of these lectures, but again, to kind of reiterate what I said there, you're looking for clinically isolated syndromes in these patients that are young and have suspected MS, and you need to look at the brain carefully for areas of demyelinating plaque. Now, for patients with diminished temporal fields like bitemporal hemianopsia, routine brain MR sequences should probably be supplemented with examination of the pituitary fossa. For an adenoma, usually that's done with contrast-enhanced thin cuts through the pituitary obtained after IV contrast. Some clinical cases here: a 35-year-old woman with blurred vision in one eye and numbness in both hands at an MR of her brain. This is an axial flare image, and it shows some areas of flare hyperintensity in the white matter of both cerebral hemispheres. Here we have a sagittal flare image showing areas of abnormal increased signal along the corpus callosum. This image shows both of those two images side by side, an axial image marking or showing areas of flare hyperintensity in the white matter, denoted by the white arrows. On the right, labeled B, is the sagittal flare image with arrows marking some of the areas of flare hyperintensity adjacent to the corpus callosum. These are areas of demyelination in this young patient who had MS. This 82-year-old woman had an acute onset of left homonymous hemianopsia, and of course you're thinking of lesions of the contralateral visual system somewhere from the chiasm back, and in this case she had had an acute stroke where the arrow marks the image. This is an axial diffusion-weighted image MR study, and the diffusion-weighted images, of course, are very sensitive to stroke, even early on in the course of the disease. This patient was 3 or 4 days out, and she had had a stroke in the occipital lobe of her left hemisphere. Cranial nerve 3, 4, and 6 symptom, that's going to be diplopia, and proper care of patients with diplopia depends on differentiating patients with double vision secondary to isolated cranial nerve abnormality from those with multiple abnormal cranial nerves. Isolated cranial nerve abnormality generally implies a benign cause and likely resolution or at least improvement of the process with time, whereas diplopia associated with multiple cranial nerve abnormalities requires an expedited workup, and you're looking mostly for intracranial abnormalities in that case. Now, in younger patients where multiple sclerosis is a concern, you need to do MR without and with contrast. For the older patients where a vascular cause is suspected, you probably need to do the MR without with contrast and also vascular imaging. Here's a 70-year-old woman with diplopia and dizziness. This is an axial flare image, and on this axial flare image you can see some increased signal intensity on the right side in the brainstem, here marked by the arrow. Here's the T2 weighted image, again abnormal increased signal, right there where the arrow is. And this is the diffusion weighted image, and this patient had had a small stroke causing diplopia and dizziness. Here it is with the arrow, and here's a composite image showing you the flare image and the diffusion weighted sequence and the abnormal signal there in the brainstem as a cause of this patient's diplopia and dizziness. So that's diplopia. Cranial nerve 5 symptoms. The 5th cranial nerve is also called the trigeminal nerve, and that's because it's got 3 divisions, supraorbital, maxillary, and mandibular. It's primarily a sensory nerve, and its chief symptom is arising from dysfunction is severe unilateral lancinating facial pain. It's also known as tic douloureux. The pain's highly characteristic, but because the same pain can be caused by multiple sclerosis or a cerebellar pontine angle tumor, MR of the brain without or with contrast should usually be performed in these patients. Note that unilateral facial pain can also be caused, of course, by dental disease, temporomandibular joint dysfunction, temporal arteritis, sphenoid sinusitis, and cluster headache. Cranial nerve 7 abnormality is Bell's palsy or idiopathic facial neuropathy. Abrupt paralysis of the facial nerve or Bell's palsy is typically very characteristic and self-limited, should be recognized by the primary care provider. It generally does not require imaging if it's isolated. As with other cranial nerve symptoms, however, when multiple cranial nerve symptoms or central nervous system abnormalities are in question, MR without and with contrast with additional thin cuts through the posterior fossa should be performed. How about cranial nerve 8 symptoms, which could include tinnitus, hearing loss, dizziness, and vertigo? Well, the 8th cranial nerve dysfunction can result in hearing loss or tinnitus if the cochlear division is involved, and it can produce dizziness and vertigo if the vestibular division is involved. Any patient with any of these 4 symptoms should first undergo an in-office hearing test, including a Weber and Rene test, and then a Dix-Hallpike maneuver to evaluate for vertigo. After that, after conducting those tests, you should be able to categorize the patient into one of the following categories to decide whether imaging is necessary and also which imaging to perform. First, the first category is isolated subjective tinnitus. Subjective tinnitus is an abnormal sound heard by the patient that the examiner does not hear. It's a frequently encountered symptom. And if the symptom's truly isolated, then you probably don't really need to do any imaging unless the patient's young and you have a strong suspicion of multiple sclerosis. In that case, you need to do the MR. How about isolated objective tinnitus? Well, objective tinnitus, that's when both the patient and the examiner can detect the abnormal noise, is very unusual. It's considerably less common than subjective tinnitus. And it's most frequently caused by vascular lesions with turbulent or high velocity flow, for example, around atherosclerotic plaque or through an AVM, arteriovenous malformation. Brain MR should be performed in these patients, and you need to do an MR angiogram and CT angiogram of the skull base and neck vessels as well as the MR. You're looking for tumor with high flow or vascular disease as a cause of that. Again, that's a very unusual symptom. You may go your whole career without ever finding one of those cases. Cranial nerve symptoms. How about isolated conductive hearing loss? Remember the Rene and Weber test are going to differentiate whether you have a sensory neural versus conductive hearing loss. And conductive hearing losses are usually caused by abnormalities of the external auditory canal, the tympanic membrane, the ossicles, or the cochlea, in other words, those structures which conduct sound to the eighth cranial nerve endings within the cochlea. Common causes include cholesteatomas, otosclerosis or hardening of the ossicles in the middle ear, and congenital abnormalities of the cochlea. Isolated conductive hearing loss does not necessarily require imaging, especially if there's an obvious cause like an external auditory canal full of debris. But when imaging is necessary, you usually want to use a temporal bone CT rather than MR, because the CT, especially the temporal bone CT, will delineate the bony structures of the temporal bone much better than MR. How about isolated sensory neural hearing loss? Well, in general, the eighth cranial nerve or central nervous system hearing loss is a lot more likely to be caused by a life-threatening abnormality like a brain tumor than neural loss is than compared to a sensory loss, which is caused by inner ear abnormality. But the two can be difficult to distinguish. When you have cases of apparent neural abnormality or where there are ambiguous findings on your clinical exam, MR done without and with contrast, with thin cuts centered at the porus acousticus in the posterior fossa is recommended. And you're looking for such lesions as a vestibular schwannoma, which was formerly called an acoustic neuroma, brainstem stroke, and multiple sclerosis as possible causes of sensory or sensory neural hearing loss. Dizziness and vertigo. Dizziness, which is, people use that term to mean a wide variety of things. It can be hard to distinguish that from vertigo, which is a sensation that the room is moving, especially when you close your eyes. Those two can be difficult to separate given patients' tendencies to describe the symptoms similarly. If the clinical history and the Dix-Hallmark maneuver indicate vertigo, and the patient has any other symptom indicating a central nervous system process like diplopia or dysarthria, dysphagia or weakness or numbness, then you really want to do an MR without and with contrast with thin cuts through the posterior fossa. Even without these features, if the vertigo doesn't show rapid clinical improvement, you should probably do imaging. Patients with balance or gait difficulties, whether they're dizzy or not, particularly if these balance or gait difficulties are accompanied by other neurologic symptoms or findings, should probably undergo MR to work up the abnormality. And of course, you're going to have a large number of patients who have mixed symptoms, tinnitus, hearing loss, dizziness, vertigo, some combination thereof. If you have any of these symptoms accompanied by other cranial nerve symptoms, headache, gait, coordination abnormalities, or any other symptom suggesting a posterior fossa abnormality, your MR should be done, and you're looking mainly again for vestibular schwannoma, stroke, brainstem, cerebellar tumors. Here's a 36-year-old man who had balance difficulties and slurred speech. The sagittal T1 weighted image shows hypoplasia of the cerebellum here, marked with an arrow. The axial T1 weighted image also shows marked volume loss of both cerebellar hemispheres. And this 36-year-old man had actually quit drinking several years before this MR was obtained, but he'd already kind of pickled his cerebellum and had alcohol-related cerebellar atrophy. And this produced balance difficulties and slurred speech. Here's a composite marked A and B with arrows on the abnormal cerebellum. This 55-year-old woman had sensorineural hearing loss, tinnitus, and headache. Here's an axial T1 weighted image with a relatively subtle lesion at the porus acousticus on her left side. Here's the T2 weighted image. And here on slide 58 is the T2 weighted image with an arrow marking the tumor of the kind of extending out of the internal auditory canal and indenting the brainstem. Here's a blow-up of the same picture showing the lesion. Here's a pre and post contrast image. The image on the left has an arrow marking the lesion prior to administration of contrast. The image on the right has the lesion with the arrow marking the contrast-enhancing lesion. And as you can see, the lesion actually extends a fair distance into the internal auditory canal, has grown out, and is indenting the brainstem. This is often called an ice cream cone type lesion, and you can see it's kind of like an ice cream cone on edge or on end. Here's another picture of the ice cream cone with a coronal plane with the tumor growing out of the internal auditory canal and along the cerebellopontine angle, here marked with an arrow. Here's a composite of all four of those pictures, again noting the tumor growing out of the internal auditory canal and into the cerebellopontine angle. This 45-year-old woman had tinnitus and headache and was a renal transplant patient. So again, you're going to do an MR because you're worried about such things as tumor or infection. In this case, there's a lesion in the brainstem accounting for her tinnitus and headache. T2 weighted image shows the lesion as an area of high signal intensity, here marked with the arrow. A little higher up on slide number 68, we see a subtle lesion in the patient's left hemisphere, marked here with an arrow. And this patient had separate lesions of the brainstem and left hemisphere. I assumed that this was probably an aggressive infection in this immunocompromised patient because he had a renal transplant. Unfortunately, this was a very rare metastatic tumor. It was a non-pulmonary small cell, metastatic small cell cancer that was metastatic to the brain at the time she presented with dizziness and headache. This 82-year-old woman had balance difficulties, mental status changes, and vomiting. And on her MR exam, you see two separate lesions in the posterior fossa, here marked with the arrows. This is a pre and post contrast exam. The contrast enhancement is more uniform but kind of peripheral on the lesion, which is more midline, and on our left, the patient's right. The other cerebellar hemisphere lesion is apparently largely cystic or necrotic because it enhances along the edge, but not so much in the middle. Here's a supratentorial lesion in the same patient in the occipital lobe of her left hemisphere, and that's marked by an arrow. This woman was known to have lung cancer, and these were all metastatic deposits from her lung cancer. So that's it for cranial nerve symptoms. It's a lot to think about, but in general, remember, just in review, isolated cranial nerve symptoms usually are, going to be benign, self-limited, get rapidly better. Possible exception to that would be tic douloureux or fifth cranial nerve, severe unilateral facial pain, where you might facilitate getting an MR to make sure there isn't an intracranial tumor. Most of the other ones, symptoms like diplopia, typically if they're isolated cranial nerve abnormalities, will resolve relatively rapidly. Otherwise, if they don't resolve, or if there are features of more than one cranial nerve that's abnormal simultaneously, or if you have constitutional symptoms loss of balance, weakness, headache, etc., then you usually need to do a brain MR to figure out what's going on with those patients. So that's cranial nerve symptoms. All right, how about sinusitis? Well, patients with symptoms of sinusitis, the diagnosis is usually based on pleural discharge and nasal congestion or facial pain or pressure. It's not usually possible to tell from patient symptoms whether a patient has acute viral rhinosinusitis or acute bacterial rhinosinusitis. However, current recommendations favor supportive care, actually, rather than antibiotic treatment, even for acute bacterial rhinosinusitis in the absence of severe pain or a temperature over 101. So imaging, that's official recommendations. I don't really see people doing that much. I see people treating people that they think have acute rhinosinusitis with antibiotics, but the official recommendations call for you can't really tell which one it is, so you don't treat except for supportively. All right. Imaging of patients with a clinical diagnosis of acute sinusitis is not typically required, usually not helpful. There's a lot of asymptomatic healthy individuals that have sinus abnormalities that overlap with those in sinusitis, like mucous membrane wall thickening, even in fluid levels. Imaging can't distinguish viral from bacterial sinusitis anyway. Imaging and even CT doesn't correlate very well with the severity of the disease. So you have patients with pretty bad-looking sinuses on CT that have minimal symptoms, patients with rather minimal disease on CT that have bad symptoms. Plain films are even worse. They're both insensitive and nonspecific compared to CT in the evaluation of sinusitis. CT of the sinuses benefits patients with symptoms in certain specific circumstances. So what are the circumstances where CT is useful? It may be helpful to refute sinusitis as a cause of pain. A normal CT supports a diagnosis like allergy or non-allergic rhinitis and atypical facial pain, as opposed to acute viral rhinosinusitis or acute bacterial rhinosinusitis in patients with equivocal symptoms. So if you want to exclude sinusitis, have your normal CT, that's helpful. Also, when you have superimposed symptoms suggesting complicated sinusitis, such symptoms could include severely diminished visual acuity, diplopia, periorbital edema, some of those cranial nerve symptoms, severe headache, altered mental status, and then usually you're doing a CT in these cases to exclude extension of infection outside the sinuses, or maybe provide an alternative diagnosis instead of sinusitis. The other case where you can use CT is for mapping where functional endoscopic sinus surgery is contemplated. Now, here's a 77-year-old with nasal drainage, headache, and a swollen forehead. In other words, some of those ancillary features that I was telling you about where you might want to do a CT. On this CT, this is the level through the frontal sinuses. Those frontal sinuses are completely opacified, noted here with the arrows. Those should have air within them, and instead they're full of soft tissue. Here's a blow-up of the frontal sinuses, and there's some worrisome features here. There's a hole in the frontal sinus that's open to the anterior aspect of the forehead overlying frontal bone, so there's been destruction of that portion of the bone by severe sinusitis. There's another hole on the inner table leading into the cranial vault. So these patients, this is a case where you can definitely have a cerebral abscess or cerebritis as a consequence of having severe complicated frontal sinusitis. Here's a sagittal picture on bone windows on our left and soft tissue windows on our right, and here we see the explanation of the patient's swollen forehead. The sinusitis is extended through by destruction the frontal bone and is hanging out underneath the patient's skin anterior to the frontal sinus. Here's some arrows marking the hole in the bone, the frontal bone, and then soft tissue extending out over the forehead, superficial to the infected sinus. So, bad day with sinuses. Now, so the other circumstances where CT can be helpful is for mapping in cases where functional endoscopic sinus surgery is contemplated. So what's functional endoscopic sinus surgery? Well, functional endoscopic sinus surgery, or FAS, was developed as a less invasive alternative to standard operations. In your classic standard surgical treatment for sinusitis, or the Caldwell-Luck procedure, the surgeons strip the mucosal lining from the sinus. They open the medial wall of the maxillary sinus to the anterior aspect of the inferior meatus of the nasal vault. And unlike the Caldwell-Luck procedure, FESS restores a normal mucociliary transport by clearing obstructions to the mucus flow, particularly along the maxillary infundibulum, the nasofrontal duct, and the osteomeatal unit. Performance of the directed surgery depends upon obtaining a map of the exact location and the cause of any obstructive process. Now that is going to entail doing a sinus CT performed either in or reformatted in the coronal plane, because that's going to best show you your maxillary infundibulum, nasofrontal duct, and osteomeatal unit. Knowledge of any anatomic variants that may represent a hazard is necessary. Given the endoscopic nature of the surgery, you have to know about these variants like dehiscence of the lamina propria and the sphenoid sinus walls to avoid inadvertent puncture of the orbit or the intracranial internal carotid artery. If you puncture those structures during functional endoscopic surgery, disaster can result. And CT will provide a roadmap of those kinds of abnormalities. Here's a 64-year-old woman with symptoms of recurrent sinusitis that had CT. The white arrow is at the cribriform plate level, and you can see there's not a whole lot of bone separating that portion of the brain from the sinus. The surgeon probably wants to know that. The black arrow is on the lamina propria, or that thin portion of bone separating the medial wall of the orbit from the nasal cavity. And in this case, there's probably a pretty good lamina propria, although if it's real thin there, you want to know that too. The surgeon wants to know that. Here, the carotid canal along the posterolateral aspect of the sphenoid sinus is pretty thin, and certainly you don't want to go sticking a scope into that or through that, or taking a biopsy of that throbbing red mass in the back of the sphenoid sinus. The sinus CT will provide information for the operating surgeon as to what's going on with the anatomy. Now, what do CTs of the sinuses show? In cases where CT was performed, an eminent researcher in the field of ENT radiology named Harnsberg noted that most patients can be classified into one of the following categories. About 40% are going to have a normal study, and then, as we noted before, in the presence of sinusitis symptoms, a normal study supports the diagnosis of allergic sinusitis, non-allergic rhinitis, or maybe atypical facial pain. 30% of patients in his big series had abnormalities that fit no specific pattern. That's called sporadic or non-obstructive disease. And then 30% had abnormalities that fit into a specific or non-sporadic inflammatory pattern. These are the patients where FESS should provide some benefit. Subsets of this group include those with a maxillary infundibular pattern, a nasofrontal pattern, and an osteomeatal unit pattern. Here's a 76-year-old with chronic headache and nasal drainage. You can see the maxillary sinus on the patient's left side is opacified, or nearly completely opacified, with a little dollop of air anteriorly. This patient's on his back, of course, nose up in the air. Here's another cut through the ethmoidal air cells. The ones on the patient's left side are largely opacified, particularly anteriorly. Here's the frontal sinus in the same patient. The one on the left, again, is opacified, and this is going to represent a classic osteomeatal unit pattern of infection, which should respond to functional endoscopic sinus surgery. Here's a coronal image showing maxillary sinus opacification. A lot of soft tissue in the left nasal valve and extending up into the ethmoidal air cells. Here's a white arrow showing that outlet of that maxillary sinus is kind of completely obliterated with soft tissues. On the other side, here's a composite picture A and B. On the other side, where there's a black arrow, that shows you kind of the normal pristine anatomy where the flow of mucus and other material out of that sinus can go easily into the nasal valves, and on the abnormal side it can't flow because of obstruction of soft tissue. So that's it for sinusitis. Again, typically you won't need to do imaging of patients with sinusitis. Bacterial and viral sinusitis features overlap both on imaging and clinically. You do want to do it if you're going to have functional endoscopic surgery, or if you want to exclude sinusitis as a diagnosis, or in those patients that are sick and have a swollen forehead, severe headache, visual symptoms that suggest a complication of sinusitis. And usually you can get a sinus CT to figure that out, although sometimes MR is helpful as well. All right, so that brings us to the third topic of the three big topics I wanted to cover today, and that's neck lesions. What about neck lesions? Well, the message here is that thyroid lesions, the main issue here is that the first step in the evaluation of your neck mass in an adult would require distinction between thyroid lesions and lesions outside the thyroid gland. If it's not possible to make the distinction on clinical grounds, you can do ultrasound. In general, thyroid lesions can undergo fine needle aspiration without imaging, where non-thyroid neck masses in adults usually require a CT scan. All right, how about thyroid lesions? Many patients have thyroid lesions, and most of these lesions are going to be benign, but it's not possible to say with acceptable accuracy which lesions are benign and which are malignant on the basis of a clinical exam alone. Both nuclear medicine and ultrasound have been and can be used for evaluating these palpable thyroid lesions, but imaging features aren't sufficiently accurate to make distinction between benign and malignant lesions either. Solid, mixed solid, and cystic, even apparently purely cystic lesions on ultrasound exam may be malignant. Therefore, it's typically stated that, or it's usually stated that it's more cost-effective to obtain a fine needle aspiration biopsy or FNAB of the thyroid lesions. It's better to do that than it is to perform imaging. Gives you your answer. Now, biopsy results are generally going to fall into one of four categories. Non-diagnostic, in which case you either repeat the biopsy or you need to excise the nodule. Benign, where you're going to at most follow up those lesions. Suspicious or indeterminate, those usually necessitate surgical excision of the biopsy. And malignant, which of course requires excision, typically of the thyroid gland. For thyroid lesions that are evaluated at ultrasound and which may or may not be palpable, in other words, you see it on the ultrasound because you did the thyroid ultrasound for some other reason, or you feel a thing. Your current recommendations for lesions include biopsy of lesions greater than 15 millimeters unless microcalcifications are identified. If you see microcalcifications, you can biopsy down to about 10 millimeters. This is recommended by most professional societies, but in practice there are many practitioners who biopsy at lower sizes. For thyroid lesions that are evaluated at ultrasound, again, your recommendations are down to 15 millimeters or bigger, like this lesion. You should go ahead and biopsy smaller lesions. Biopsy at least if they're 10 millimeters and have microcalcifications. So that's thyroid lesions. How about non-thyroid neck masses? Well, non-thyroid neck masses are malignant until proven otherwise. Adult neck masses outside the thyroid gland, especially in patients over the age of 40, and especially when they have known risk factors like smoking, you really have to think of tumor cancer. These patients typically need referral to an otolaryngologist for treatment. And while such clinical features as a soft, rubbery consistency and mobility favor a benign cause compared to hard-fixed lesions, these clinical features aren't in themselves diagnostic. Note here that I'm talking about adult neck masses and that pediatric neck masses have a different set of considerations. They often represent benign cystic lesions or hemangiomas. Now, almost all these masses, almost all neck masses that are outside the thyroid in an adult will usually need a CT scan performed without contrast. And the scans usually goes from the arch of the aorta down here all the way up to the skull base. It's usually called a neck or soft tissue neck or head and neck CT. You usually want to put a marker at the location of the palpable lesion in the neck. If the patient can't locate the lesion or it's not obvious where the lesion is, then before you send the patient for the scan, if you feel the lesion, go ahead and mark it with an indelible ink marker prior to sending the patient over, and then that way the tech can put a marker on it when the scan is done. You may want to pretty strongly consider getting a chest CT at the same time, because these same patients that get neck masses get chest masses are usually smokers. Given the fact that chest primary tumors can either coexist with a neck primary or be a source of metastatic deposit, it's another reason to get the CT scan. Sometimes a CT can suggest a cyst where you have congenital developmental abnormality, like a branchial cleft cyst, or it can provide a specific histologic diagnosis sometimes. Here's a 32-year-old man with a palpable neck lesion. A and B are both shown. This is a pre-contrast and post-contrast axial CT scan. You can see the mandible anteriorly. Contrast enhancement on our right, the image labeled B, you can see the carotid vessels and jugular veins lighting up with contrast. The arrow is on the lesion, and you notice a little white dot on the skin surface superficial to the lesion that the tech placed because the patient had a palpable abnormality of the neck. This was actually of low density, circumscribed, showed no contrast enhancement, all of which are features which are pretty typical of a benign cyst. This patient did have this removed, and it was found to be a branchial cleft cyst. These are developmental anomalies that patients can have in their neck and cause a clinically palpable lump. Sometimes these get infected, and usually they end up being resected because they're prone to intermittent infection, pain, or some other process, although this guy was 32 years old before it actually came to much attention. Here's a 62-year-old man with a palpable neck mass. This is a CT scan through the upper chest or lower neck. You can kind of see the ribs there adjacent to the thoracic vertebra. Trachea in the midline in the front, and right down at the base of the neck on the patient's right side, here marked by the arrow, there's a triangular area of decreased density, so decreased in fact that it's the same as the subcutaneous fat, the fat in the axilla next to it. Here's a little higher cut on the same patient, and again, an arrow on the lesion. You can see that there's a pretty large component of fat in this lesion. It follows fat on, or is the same as subcutaneous fat and fat in the contralateral neck. Up higher yet, it continued to dissect up or grow up in the patient's right neck. And here it is with an arrow. Here's this coronal and sagittal reconstruction examination through this patient's neck showing the lesion, and this was pretty well contained, sharply marginated, a benign lipoma in a patient with a palpable neck mass, here with arrows. So while CT can occasionally demonstrate features such as your cyst, or on rare occasion even establish a diagnosis like a lipoma, the main purpose of the CT is to demonstrate the exact location of the lesion, demonstrate any other non-palpable lesions that coexist, and to search for a primary tumor, since many palpable lesions of the neck represent metastatic deposit from oropharyngeal mucosal primary tumors. Let me say that again. A lot of the palpable lesions in the neck will actually represent nodes, and those nodes are metastatic deposit from a primary oropharyngeal mucosal tumor, squamous cell carcinoma. That's your most common cause of a palpable neck mass. It's malignant. Here's a 74-year-old man with a palpable neck mass. And again, you can see the marker on the image marked A, superficial to the lump. In this case, unlike the other fellow, the lesion's a little bit less well defined. It's not cystic, it actually shows some contrast enhancement, and it's kind of bulky and ugly. This ended up being a squamous cell cancer of the head and neck with metastatic deposit to this node. Now, the location of the palpable abnormality can provide a clue to the location of the primary tumor, since tumor cell drainage follows a typical pattern. As an example, the submental lymph nodes drain the lower lip and the floor of the mouth and the apex of the tongue. So if you know this pattern, it can help the radiologist and the otolaryngologist search the associated mucosal surface that goes to that particular lymph node. However, a lot of area goes to the jugular-gastric node, usually you're going to perform laryngoscopy and esophagoscopy or bronchoscopy to identify the primary lesion in these patients anyway, but it does kind of help you direct your search. So unfortunately, even with the location of the primary lesion and knowing what the spread pattern usually is, even knowing the location of the lymph node and knowing the patterns of spread, the primary lesion may not be found on CT or endoscopy. In that case, the usual next step is to get an FNAB, or fine needle aspiration biopsy of the palpable lesion. And if that lesion is malignant, when you haven't yet found a primary tumor, the next step is typically random biopsy of the nasopharynx, palatine tonsils, and base of the tongue. And that's what you do with neck masses. So again, neck masses inside the thyroid gland, if you can feel it and it feels, over a centimeter or so in size, especially over 15 millimeters. If you can feel something in the thyroid gland, fine needle aspiration is your best bet. That's cost effective, and you can usually place the lesion into one of a few categories. If you see a lesion on ultrasound, for example, doing a carotid ultrasound examination for stenosis or atherosclerotic vascular disease, you happen to see a lesion in the thyroid incidentally. Lesions over 15 millimeters typically undergo biopsy, or over 10 millimeters if they have microcalcifications. Routine ultrasound or nuclear medicine of palpable thyroid lesions is probably not cost effective, so you don't really need to do that in most cases. Non-thyroid adult neck masses that have that are outside the thyroid gland, especially if the patient's over 40, especially if the patient's a smoker, you really have to think in terms of a metastatic deposit from squamous cell cancer of the oropharyngeal nasopharynx, and that mucosal tissue developing a tumor metastasizing to a node in the neck. So you want to do a CT scan of the neck with contrast from the arch of the aorta up to the skull base to look for the node, any primary tumor, any additional non-palpable nodes elsewhere in the neck. Once you do that, you usually need to get a biopsy of the node, but also try to find the primary tumor and figure out what the cell type is on it. So that's neck masses. So in summary, cranial nerve abnormalities may require MR of the brain. Again, any time a patient has multiple cranial nerve abnormalities, or even has isolated cranial nerve abnormalities but has additional symptoms like headache and or constitutional features, you should be thinking in terms of a brain MR. Isolated single cranial nerve symptoms, often they can show pretty rapid improvement, and you may not need to image those. Again, patients with symptoms of sinusitis usually don't need imaging. When you do need to image them, CT is usually your study of choice. When would you image someone? Well, to exclude the diagnosis of sinusitis, for functional endoscopic sinus surgery, and then when patients have superimposed additional symptoms like a severe headache or cranial nerve abnormality, etc. And again, thyroid lesions can undergo FNAB without imaging. Non-thyroid neck masses in adults typically require CT scanning. Thank you very much.